My name is Tom van den Bogert. I'm the past president of the International Society of Biomechanics. And in the past year, it was my duty to chair the selection committee for the Muybridge Award. The Muybridge Award is named after Edward Muybridge, who invented high-speed photography, and that's what allowed us to study movement of humans and animals. The Muybridge Award is given for career achievements in biomechanics, and it is the most prestigious award in the ISB. In the selection, I was assisted by the other members of the committee, past winners of the award, Peter Kavanagh and Ben O'Neill, and also the president of the ISB, John Chalice. In selecting a winner this year, the committee looked especially at impact on the field of biomechanics. Professor Kai-Nan An showed this impact in several different ways. First of all, his extraordinary productivity, which can be quantified by the number of 700 or more publications, and they've been cited more than 20,000 times. Another way that he demonstrated his impact is by doing research that had impact on the clinical practice in orthopedics and the development of new surgical techniques. I would now like to ask Dr. Kenton Kaufman of the Mayo Clinic to introduce Kai-Nan An.
It's my privilege to introduce Professor An to you. Professor An was born in mainland China. His father, Chung Sung An, is a chemical engineer, and his mother, T.U. Tong, was a textile engineer, so he grew up in an engineering family. He has one sister, Ying Mei Ha. Following the war, they migrated to Taiwan, where he's received his bachelor's degree from National Cheng Kung University. Following that, he came to the United States to get both a master's and a PhD in applied mechanics from Lehigh University. Following his formal education, he traveled to Mayo Clinic to engage in a research fellowship. He arrived there in 1975, shortly after the lab was formed, which was in 1972, and the lab was started by Dr. Y.S. Cha. The lab was the idea of Professor and Dr. Mark Coventry, who performed the first total hip replacement in the United States in 1969, realized the importance of engineers working with physicians to further the field of joint replacement. This shows the lab at that time. Now, the lab was located in the basement of the Medical Science Building, and it was located next door to the primates. Once in a while, some of the primates got out of their cages and visited the laboratory. Professor An has spent his lifetime career at Mayo Clinic. He's the John and Posey Crable Professor of Orthopedics, Professor of Bioengineering, Distinguished Investigator, Director of Biomechanics Lab, and a consultant in the Departments of Orthopedic Surgery, Physiology, and Biomedical Engineering. Over his 40-year career, he's published 750 peer-reviewed papers, averaging 30 papers per year over the last 2 decades. He's focused primarily on the upper extremity. He's worked on the hand, the wrist, the elbow, the shoulder, but he's also worked on the lower extremity. He's been cited 20,000 times, and he has 7 patents. This is how I think Dr. An views the world, because of his interest in the upper extremity. He's received numerous awards. He's received the award from the ISB previously, the highest award from the American Society of Biomechanics, and the Taiwanese Society of Biomechanics. Because of his work in orthopedics, he's also received the top awards from the American Academy of Orthopedic Surgeons, the Orthopedic Research Society, the American Shoulder and Elbow Society, and the American Orthopedic Society for Sports Medicine. He's a past president of the American Society of Biomechanics. He's served the National Institutes of Health in numerous ways, including the Director's Award. He's a founding member of AMBI. He's had a leadership position in the Orthopedic Research Society, and he's been on the advisory board for the World Association for Chinese Biomedical Engineers. He has mentored numerous individuals over those years. In fact, he's mentored over 316 fellows from 29 countries and 6 continents during his time at Mayo Clinic. This shows the lab in 1981. Professor An is in the back row. You may also recognize Dr. Eric Schneider, who was the head of the AO group in Switzerland, and Professor Rick Huskis, who was a previous winner of the Muybridge Award, and Joan Beckeld, who's a past president of the Orthopedic Research Society. This is Professor An in 1985. This is when I first met Professor An. It was my privilege to first of all, be trained by him and then to work with him. This shows the biomechanics lab today, Professor An. Now, those of you that know Professor An know that the most important thing to him is his family. In addition to his parents and his sister, he has a lovely wife, Sue Ting. I'm sure we'll talk about his two lovely children, Ting and Ming. Ting is married to Christian, and Ming is married to Paul, who's not shown in this photograph. He also has two grandsons, Ryder and Nolan. Ladies and gentlemen, members of society and guests, it's my honor to introduce the 2015 Muybridge Award to Professor Kai-Nan.
Good afternoon. Thank you, Ken, for your very kind introduction, and even brought me back a lot of history. And thank you, Tom, and also the committee members just mentioned. I'm very humbled to give this particular honor. I know there are many qualified people should be here instead of myself, but I appreciate this opportunity. And also, of course, I like to give my thanks to all my friends throughout the year. Some of friends I just made a couple of days ago, up to the friends I knew for more than 30 years. With their encouragement, their support, their advice, so I'll be able to survive in this particular field for probably, I don't want to say 40 years, 39 and a half years. So, as Ken described, my interest in and my expertise basically is in biomechanics of upper extremities. So this also probably represents a great honor for all the colleagues who work in the upper extremities. That means that we probably, if not work in the field, it's neglected. So probably one of these days will be recognized. So Muybridge, of course, everyone knows this famous picture of his horse racing with a camera, so be able to identify the pattern, the gait of the horse. So they do have a great contribution, not only scientifically, but also financially. But by digging out through the film, I found out, indeed, he also has the interest in showing the upper extremities, in this case, lifting, passing, and also you can see the shoulder movement. So I think it's quite pertinent to present biomechanics of upper extremity under his honor. As Ken just briefly introduced, the laboratory was founded in the early 70s based on the interest of the joint replacement at Mayo. Of course, everyone knows Charlie in England, who developed the total hip for joint replacement. But in America, Mark Coventry, he was the department chairman in the late 60s. He was the one responsible for the joint development in America. And he put it in the first FDA-approved total hip in 1969. Then he recognized the importance of in-house research. That's why he recruited Edmund Chow. He was a junior faculty at University of Iowa at that time. With the support of these 4 physicians, of course, at that time, these two were a little bit more mature. These two were still resident. Dr. Ron Linchan and Dr. Stauffer really helped him start with this laboratory. On the other hand, Dr. Cooley and Dr. Mori, as just finished a young resident, really stimulated him because Dr. Chow still reminded me he was not quite sure if he should take this job because he has a job at Iowa. He was not sure if this is a really serious job or not. But these 2 young residents finished their surgery, finished their clinic work, they always come to the laboratory. So make him feel this is a really serious business. So he was recruited basically to help out development of total hip replacement and eventually total ankle joint replacement. In 1975, as Ken mentioned, I finished my school at Lehigh University. Then I was given the opportunity to join Dr. Chow for his laboratory. Basically, my assignment is to take care of joint replacement for upper extremities, especially to start with hand. Throughout the year, of course, we was successfully developed all the joint replacement in this slide, as you can see, for finger and for the wrist. And we developed different methods to test out the endurance of this implant. And we also have some analytical approach and to understand, to design, to improve the design of this is a representation of implant for the elbow and shoulder implant replacement. But what I'm going to do, I'm not going to dwell on this joint replacement, but I'm going to just quickly share with you a few of the clinical accomplishment in terms of clinical translational application based on the outcome from the laboratory research. As Tom just pointed out, we do closely work with all the surgeons in the Mayo Clinic because this nevertheless is a clinical setting. So I will just using this opportunity to give a little bit of science, but more important to use this opportunity to share with you some of this accomplishment and hopefully can stimulate young people to carry on research and see their eventually contribution. So the first topic I will going to focus on is on the joint stability. We all know these are all the anatomical structures which provide the constraint of the joint. As I always said, there are the anatomical structures, but the constraint and the stability of this human joint are accomplished by the integrated function of all these anatomical joint and the elements. You cannot say which one is most important, which one is not important, but eventually they all work together to accomplish static as well as dynamic joint stability. So from the static point of view, you start with capsule ligamentous structure. As throughout the day, you can see there are quite a few modeling, try to looking at the contribution of the ligament capsule to joint constraint, the limitation of joint range of motion. Basically, if you can monitor the change of length, basically eventually can change to the strength, the line of action of these fibers, and the material property. Theoretically, you should be able to predict what will be their relative contribution to constrain the joint. Same thing applies to the elbow joint. For example, on the top right side, showing that the radial collateral ligament is more or less centrally located. So that's what the length change is constant, isometric. Their contribution will be equally throughout the joint rotation. On the other hand, for medial collateral ligament, they are off-centric loading, so their contribution could be at more flexed position compared with extended position. So experimentally, there were two methods being used in the past to assess the relative contribution of a ligament. First one is the stiffness test. Basically, it's based on the displacement control. So namely, you displace the joint. You rotate the joint to extreme. You distract the joint to extreme. Then you sequentially section the ligament. Then you will see the force, the moment required to displace the joint systematically decrease. Then you can appreciate the contribution of that particular element of the soft tissue. The second one is a laxity test. Basically, you have load control. You subject the joint to a vagus stress or varus stress. Then observe how much additional laxity being generated with the sequential removing of the passive element. So these are the two complementary approaches to help out to understand this. Just this is the slide as I indicate. The top one shows the intact, the bottom one shows if you section one of the soft tissue element. The difference will be the contribution of that particular element. So in the elbow joint, of course, we repeat the same experiment. We cut medial collateral ligament, or sometimes we call the ulnar collateral ligament. Then you can see tremendous decrease. So you know that is the important ligament to constrain the vagus stress of the elbow. That is why the Jimmy Jones procedure is so important for the baseball pitchers when they lose their particular ligament. So again, using this, we remove the radial head first, we remove the medial collateral ligament second, then both ways confirm that medial collateral ligament is the primary constraint. On the other hand, the radial head is a secondary constraint. So we further confirm this by using the laxity test. So we put the elbow specimen subjected to a constant varus stress. As you can see, if you remove the radial head first, not much change. But on the other hand, if you remove the medial collateral ligament, again, the laxity increased tremendously. So if you change the order, you remove the medial collateral ligament, they change immediately. Then if you further increase the radial head, then you lose the stability. Then on the radial side, of course, when Dr. Sean O'Driscoll, that time he was a young orthopedic surgeon, he came to the lab for 1-year fellowship with careful dissection, and he found out there is one ligament which was not recognized in the literature before, because always at that time people think on the medial side of the elbow you have medial collateral ligament, on the ulnar side of the elbow basically you have radial collateral ligament, which is insert from the distal humerus to the radius. But indeed this is a particular ligament which originate from the distal humerus, but passing through the annular ligament, but eventually insert into ulnar. So indeed, it is a true ulnar collateral ligament. So in the laboratory, we did all the tests. We found out its relative contribution. If you sequential cut, you can see laxity increase. However, if you reconstruct that ligament, laxity immediately reduced. So based on further tests, we try to understand how does that particular ligament contribute to the joint and the different type of loading. And he developed this technique for diagnosis to see if this particular ligament indeed is...
The following video is part 1 in a 2-part series on posterolateral rotatory instability of the elbow. This video describes the mechanism of injury and how to perform the posterolateral rotatory drawer test. The most common mechanism of injury for posterolateral rotatory instability of the elbow is an axial load followed by valgus and supination. Patients typically present with a history of trauma or lateral elbow surgery. The most common symptoms are pain or sensation of instability that can often be accompanied by mechanical clicking. Although a number of special tests have been described, the posterolateral rotatory drawer is the most critical portion of the physical exam. It is performed with the patient in the supine position and the arm overhead. The forearm is fully supinated and held securely between the examiner's upper arm and their body. A slight valgus force is in place in the distal humerus, and a posterolateral force is applied to the radius. Note the clear posterolateral subluxation of the radial head here.
Anyway, let's demonstrate one of the outcomes from this type of research. Eventually end up he has a very accurate clinical diagnosis for treating a lot of unstable elbow joint. So not all the joint we can perform this type of assessment, especially if you cannot hold the extremity to perform this manipulation, such as the carpal bone in the wrist joint. In that case, we have to rely on the imaging method to do the assessment. For example, the carpal bone has all the 7 bones with all the ligament interconnected. So that's what in the early days we developed this biplan or stereoradiographic method. Then you'll be able to, by putting markers into the bone, then using the digitizer, as you can see the technique is very, very old. Eventually, you can do all the assessment. In this case, we look a lot of the importance of the ligament in constraint the carpal stability, especially nunoscaphoid dissociation, nunotracheal dissociation, and look at different surgical technique in order to repair this.
One-time Dodger Jason Ward. Jason, for what it's worth, Buffalo Springfield fan, up to the plate. Jason had a very odd and not diagnosed correctly ligament injury in his wrist. They couldn't figure out what the problem was. I told him before the game, and he said that they found the doctor at the Mayo Clinic, the famed Mayo Clinic, that said, wait a minute, this ligament is completely different. It's hard to describe, but it was kind of twisted totally. It's not one that usually causes baseball players problem on the outside.
Anyway, that is a clip from this Jason Ward. Probably for those who come from America recognize this person, and he's a very worthwhile person, $20 million per year. So if he has a wrist problem, he cannot play, then you can see how much financial loss. But anyway, he had a trouble. He traveled around and cannot find the problem and the solution. So he come to Mayo Clinic. My colleague, Dr. Dick Berger, immediately, based on his experience, he found out the problem is because the location and based on the symptom is associated with the ulnar tracheal ligament. Of course, this is not easy because the injury is not a typical avulsion failure. You cannot see the damage on the MRI or even on the X-ray. So, but this is the damage basically described in this video. It is twist, spirit failure of the tendon. Because this particular ligament is located at the distal ulna to the tracheatrium, which is along the line of the forearm supination rotation. You can see this particular line was subjected to a lot of a twist. So you can imagine with this twist of a torque on this ligament, end up is not a avulsion failure separate into two, but instead the split in between. So it's very difficult to make a diagnosis, but based on his experience of the couple bone research in the laboratory, that's what I believe gives him the intuitiveness and to make the right diagnosis. So more recently, of course, the imaging development, the development of medical imaging moves very fast. So we try to take advantage of that. This is the imaging based on the 4D CT. As you can see, in the past, we have to do the stereo photographic or stereo radiographic method. Nowadays, we can look at the dynamic imaging of the carpal bone motion in the 4D CT. Of course, you can do a lot of, just by looking at the picture, the surgeons or the physicians be able to make their diagnosis. But as an engineer, we should be able to do further quantification. In this case, we look at the proximities between the joint, so we'll be able to identify the impingement of the articular surface due to the abnormal kinematics. So quickly move on to the second part of the joint stability. Articulating surface is also very important. But in order to take advantage of articular surface for joint constraint, you have to have a concurved surface. You also have to have a compressive force. Without compressive force, even you have a curvature, you will not be able to benefit too much. So based on this principle, in the laboratory, we build up these 4-axis machines, so we'll be able to rotate translate in all three directions and rotate in one direction. So based on this, we should be able to assess what is the combination of the compressive force and the surface geometry to the joint stability. We spent quite a lot of time by looking at glenohumeral joint. As you can see, their relative contribution, as indicated in these red slides, are not equally distributed in all directions. In superior inferior direction, the joint contribution, articular surface contributed more compared with anterior posterior directions. So based on this, we also did an extensive study in case you have a bony defect, how will that affect the stability? Nevertheless, we conclude that somewhere between 17 and 25. If beyond 25, you have to do something, otherwise the joint will not be stable. Then we did a lot of study by using different type of a bone graft to restore this type of function, using different procedures such as Latarjet procedure to restore this type of function if you have a Bangkok lesion along with a bone defect. So not all the defect taking place in the glenoid part. Some of the heel sex lesion, they have defects on the human head part. And even worse, the combination is quite often as well. So the treatment protocol may not be that straightforward, just based on 25% or 17%. In case you have these two type of combination, we call the bipolar type of lesion. As you can see through this arthroscope, when these two lesions engage, then the catch will take place. So my colleague, Dr. Iji Itoi, he spent a few years in the laboratory. Now he's practicing in Japan, and he is very clever. He came up with this idea. He tried to map the glenoid surface onto the human head. Then you can see these are the area of the contact if you elevate your shoulder joint. So basically, in case you have a bipolar type of lesion, it is a mutual relationship. It depends how much the damage on the human head and how much the defect on the glandula. So with the condition in mind, for example, in this case, if the lesion on the human head cover the glandular tract, then you will have a chance to catch. So in that case, then you need to repair the heel sac lesion. But in this case, if you can also repair your glandular, so you increase your tract space. So in that case, the lesion in the human head will not be that important. So this will be important for your surgical decision. Intra-articular pressure is very important, especially in shoulder joint. Indeed, the intra-articular pressure changes in all the joints, but some of them you do not observe that, especially for the lower extremity. Since it's a weight-bearing joint, we don't see that. But for upper extremity, as indicated in these slides on the far left, if this is intact joint, the joint is well seated. But if you use a needle puncture it, then you immediately can see the joint drops. In fact, if you use a needle sucking the air out, you can see this will restore. So this just indicates the importance of intra-articular pressure to contribute to the joint constraint. This is slide I try to indicate that quite often after total shoulder replacement, immediately after surgery, if you take X-ray, you find out the joint is dislocated. Sometimes makes the resident nervous when they present this to their consultant. But fortunately, a few days later, a few weeks later, they go back to their positions. Of course, there are many factors, include the regaining of the muscle tone, but we believe the intra-articular pressure may play some important role as well. The muscle is very important. Of course, the muscle is the dynamic part. When you try to move the joint, the joint stability and the dynamic condition will be important. This is a slide demonstrated based on our theoretical analysis. Just like one of the talk probably from Dr. Peter Walk's work, I forgot, talking about the resultant force. R is resultant force. The relative location of the resultant force to the available articular surface not only is important for the pressure distribution on the joint surface, but also important for joint stability. U is we call engineering called virtual displacement. If you put this into the model, apply the load, you can see the joint try to adjust themselves. This is the direction the joint try to move and distribute the loading. If the joint, the resultant force is close to the rim, then not only you have adverse pressure distribution, stress distribution, you also influence the direction of virtual displacement subject to dislocation. Based on this principle, we try to understand why people think deltoid is important driver, rotator cuff muscle is important steerer. So combination of them, you will have a stable and a stronger joint of the shoulder. In order to talk about this muscle, of course, we also try to understand the muscle function. We're doing a proprioception type of research in the laboratory. Dr. Berger was very interested into looking at the nerve ending, not only try to understand the pain, but also try to looking at the afferent signal from each of the nerve in the capsules. So eventually this will affect all the joints. So recently there's a lot of discussion in terms of the basal joint of the thumb. As you can see, it's very typical for arthritis, especially for female population. In the laboratory, we did a lot of study. We found out the ligament constraint is very important, but we also believe that the muscle constraint is equally important. Of course, in the laboratory, we have been interested in how the muscle activities, where this place just show you the ENG study. As you can see, different function, different muscle come into the picture. Eventually, the proper training of the muscle probably can help reduce the pain through the joint and even better try to reverse the potential arthritis. And the studies such as this kinesio tape, and we just had a discussion next door for this particular one. Not much science involved yet, but clinically I should testify because myself was one of the patients. I did have a basal joint problem, but after 3 months treatment, now I can squeeze my toothpaste. But I encourage more research in this area, but we still don't have much science at this moment. Okay, quickly I will just say a few words about the other part of my research, which is related to the tendon. I just give you 2 examples which has some impact. The first one, briefly, we talk about tendon function. When I say tendon function, I should really say it's muscle function. But on the other hand, tendon is the cable which transmits the force of the muscle to the joint. So, especially in the hand, the tendon is very important because most of the extrinsic muscle are originated in the forearm. The force has to be transmitted through tendon in order to get to the fingertips. So a lot of the tendon gliding eventually will taking place, which I will talk that briefly later. So this is one of my favorite slides showing the relationship of a tendon excursion and moment arm. In the early days, we did this study for the finger joint in order to understand the moment arm. So we get this measurement. The horizontal axis represents the joint rotation. The vertical axis represents the tendon excursion. The slope of this relationship is nothing but the moment arm. This particular relationship has been validated with all the Lance-Mears model, describe all kind of tendon origin insertion and passing through the pulley. So that relationship holds true for all the potential models. As you can see, after you take that, and you get to the moment arm. So I'm going to demonstrate to you is by using this principle. Recently, my colleague, Dr. Biomch-V, he studied this, he developed a new technique for tendon transfer in treating this group of patients with BPI. With massive rotator cuff tear, you can see his right arm, he cannot doing external rotation. So in the past, there were quite a few candidates for this type of transfer, latissimus dorsi, teres major. But based on his personal study, he found out lower trapezius could be a better muscle for this type of operation. So that's why he came to the laboratory. He did a study with a small 3 potential donor and 4 potential insertion site. With all these combinations, he went through this our shoulder simulator and get the excursion and get the moment arm. Based on that, again, he found out indeed his theory, his hypothesis, the lower trapezium transfer, the too far left one, indeed perform better than other approaches. So with these things in mind, eventually he used this clinically. So for this young lady, she was involved with automobile industry injury. As you can see, his right arm not only have a BPI, but the entire arm has been destroyed. So basically, immediately they just close up the arm. But then he restored that by all the tendon transfer he performed. It's not perfect, but as you can see, it makes a tremendous amount of differences. Finally, let me just talk a little bit on the tendon gliding. As I pointed out in the early slides, especially in the hand, you have long tendon passing through the long path, include the bony turner, the carpal tunnel, include the pulley of the joint. So a lot of interaction taking place between the tendon and the surrounding tissue. That's why we believe the friction gliding will be equally important. If you have a poor friction, the tendon may be damaged earlier. I don't want to say eventually get into tendinopathy, but it is potential. On the other hand, when you have a repair tendon, for example, this is a typical post-surgical rehabilitation for tendon repair. As you can see from these slides, you know there's tremendous amount of friction. So even you have a different type of a splint design, with this amount of friction, you may not be able to really accomplish the good gliding during the rehabilitation. That's why adhesion may still form. So in the laboratory, based on this synergistic concept, if we take advantage of the wrist motion, because the wrist motion has a reciprocal functioning for the tendon excursion. So this way you'll be able to take some laxity away, then you'll be able to really accomplish the expected excursion by using these procedures. Then, of course, we look up the textbook of engineering mechanics. You found these typical equations describing the relationship between the cable tension on either side of the pulley. So the relationship is the tension on one side is related to the tension on the other side through this exponential relation of the friction coefficient and the angle of wrap. So if friction coefficient is 0, there will be no friction because F2 will be equal to F1. If the angle is 0, there will be no friction. So this equation is very important, can help out a lot of explanation for physical therapists when they try to instruct a patient doing certain things. So based on this basic principle in the laboratory, we built a very simple testing machine so we'd be able to measure all this tension on each side, assess the friction. Based on that, then we can assess the potential friction coefficient. Immediate application, of course, try to compare different surgical technique to repair the tendon. Using different technique, you can see the results are not the same. So in other words, not all the technique give you the same results. Different material, different size of suture also give you different results. So this information will be very useful for surgeon eventually to decide which method you're going to use, which material you're going to use, which will have a better gliding after you repair your tendon. Of course, in the laboratory, we also spend a lot of time trying to understand the basic lubricants involved with the tendon. Lots of lubricant has been studied in the cartilage, so we don't have to start from scratch. Basically, look and see if we can identify the similar type of lubricant in the tendon. Indeed, we found out HA, phospholipids, and more recently, lubricant has also been identified. In fact, lubricant contribute probably the most, because when using 3% take away, lubricant probably is most involved. Based on all this knowledge in mind, my colleague, Dr. Sun, he's a chemist. He developed a technique to modify the tendon surfaces. So this way you can see this is a native tendon, extrasynovial tendon. With the proper treatment, you can decrease the friction coefficient tremendously. Also make it also almost from extrasynovial to intrasynovial tendon. So with this type of a technique in mind, as you can see, when you treat the tendon repair, this is one without treatment, a lot of scar tissue formation. This is one with the treatment, you can see nice shiny surface. So these are all the, again, I'm very proud of the type of outcome eventually can benefit the patient after they have a chance for treatment. Based on the line of the tendon gliding and tendon friction, we also spend some time trying to understand what are the friction mechanisms within the carpal tunnel. And within the carpal tunnel, then we found out there's a structures called subsynovial connective tissue. This slide probably...
Dr. Peter Amadio and his research team found that people with carpal tunnel syndrome have a splitting or tearing injury in this tissue. The injury results in scar tissue that thickens and impedes movement. In severe cases, the tissue gets so scarred and stiff that it completely rips off.
Okay, so this is a tissue, as you can see, probably next slide. But anyway, in the laboratory, we designed some micro tester, try to understand the tissue, subject them to tensile, shear, all kinds of tests. Indeed, we found out their mechanical property for the normal subject and as well as for the patient, for the carpal tunnel patient, they are different. And also we try to do animal study, try to understand how the fibrosis form. Indeed, this is a tissue, as you can see, it's a very thin layer, but if you put in the microscope, you can see it's a multiple layer. Then if you subject them to tendon sliding, you can see all the layer by layer, they start stretch. That's what our hypothesis, all these micro tissues damage, which serve the initiation of the fibrosis and eventually leads to the carpal tunnel. So this information can be used for understanding in the ergonomics area, how do we improve our equipment or improve our the procedure so we be able to not put the tendon excursion, eventually the SACT in adverse condition. So this type of information, eventually by putting into the model, we can see if different type of tendon motion, what kind of stress eventually generate, where this type of stress eventually cause any damaging of SACT or not. So there's a lot of work ongoing right now. But more exciting is that this type of information eventually leads us to the study for a clinical diagnosis. Again, just like we have a few sessions earlier from the Canadian group, Dr. Kier's group also using this technique to looking at excursion of SACT. This is using ultrasound Doppler. You can see the relative motion between tendon and this SACT. Then eventually, based on the study so far, we can find out there's two groups of carpal tunnel patients with their SACT relative motion. One of them, their SACT move because they move closer to the tendon because the rupture taking place between the SACT to the transverse ligament. On the other hand, there's another group, the rupture taking place between transverse ligament and SACT. Then they move independent of the tendon. So based on this, hopefully we will be able to make earlier diagnosis or screening of the patient before they get to the stage is reversible, which require any surgical procedure. And also, a colleague in the laboratory, they are more focused on the molecular biology, try to understand the pathway for the fibrosis. Currently, they are doing anti-TGF-beta drug, see if this will be able to stop or even reverse the formation of fibrosis. If that is the case, eventually the treatment of a carpal tunnel could be accomplished by medication rather than surgical procedures. Of course, this is many years down the line, but at least the research will point out to these directions. So this just concludes my scientific presentation, but I still have a few more minutes. I really like to use this opportunity to acknowledge all my colleagues. As Ken showed earlier, this particular slide represents our annual picture for the people in the laboratory, and this represents all the staff, permanent staff in the laboratory, as well as large number of fellows. In general, we have probably between 15 to 20 fellows come from many places in the world to spend some time in the laboratory between 1 year to 3 years. So I should give the credit or this honor to all of them. Of course, among this, I cannot point out everyone, but many of these are many clinicians. But there are 2 PhDs. One is Ken Kaufman, he sits over here, and another one is Kristen Zhao, sits over there. They are my close colleagues. They contribute not only scientifically, but also the management of the laboratory. And the rest of the MDs and the clinicians, they range from fingertip all the way to shoulder. So their collaboration definitely make this research interest not only point me to the right direction, but also keep me probably more straight if, in terms of interpretation. So this is what we call in the laboratory the Wall of Fames. So these are the fellows, they spend some time in the laboratory. We have 2 boards right now. First, I thought I might retire at this time, but unfortunately we carry on. We have this is the slides we took a few years later, almost a year. So I have to really give them the credit. So I decided to take 15 seconds to roll them through. I guess they are. Initially, I tried to circle them out, but my PowerPoint skill is not that good. I circled them, but these things moved, the circle didn't move. So this is a tendon number 1. Probably you can recognize a few of them. The tendon number 2. Of course, I have many of them sitting in the audience here. I will miss them if I try to point out. But I really want to give all the credit to all of them. Without them, probably there is no research output. But finally, as Ken pointed out, the family is very important to me. I have a lovely family. These are 2 daughters and 2 son-in-law and 2 grandsons. This is a picture at Rochester Airport. After Christmas, I sent them back, so we had a picture taken. But I should really give the credit is to my wife. She's been with me for close to 40 years, not quite 40 years. And again, I can see my accomplishment probably all attributed to her dedication to the family. But unfortunately, she joined her father in heaven, and she really has fought the good fight, had finished the race, and also had kept the faith in 2010. So I should give this particular talk to her, credit to her. So again, thank you very much for your attention. I know initially at this time you should enjoy your beer and dinner at a fancy restaurant in town now. But the last minute, our host was kind enough to squeeze me into the slot. Thank you very much. Thank you very much. We still have a couple minutes. I'd like to see if any comments from the audience. If you have a question, I have a chauffeur, and here they can help answer this question. I don't know if you all heard that story. The chauffeur answered the question. I assume you all. So all my fellows down there, they can help me answer that. But I'd like to see if you have any comments or any questions. Okay.
Then with the Muybridge Award, we present a certificate and a medal, and we'll present that to Dr. An right now.